Yeah, buddy. Good morning, everybody. Or good afternoon. Reed here. Today, we're going to have our discussion on multi-infarct dementia. Now, um, the dementias, they've undergone a name change over the past, let's say, decade, right? They're usually called multi-infarct dementia or things like that, or Parkinson's and Huntington's dementia. But now they're sort of classified as what we call major neurocognitive disorders, right? And so they are all within the group, a new group called the major neurocognitive disorders, right? And then all of the dementias are sort of nestled within that broad category. And the major neurocognitive disorders basically represents all the different types of dementias that significantly impair cognitive functioning, like emotional functioning, intellectual functioning, things like that. So they don't really use the term multi-infarct dementia no more. They are also now. We needed to sort of separate the difference between, let's say, a vascular dementia and a multi-infarct dementia. Right? Yesterday, we sort of reviewed a vascular dementia. And let's see, let me just go back through. Let me just go back through the dementias real quick. Let me see here. So I'll go to, let's see here. Okay. Let me just go through vascular dementia real quick. Remember, the vascular dementia is when the blood vessel pops in terms of a hemorrhagic stroke, or when the blood vessel is occluded, such as a ischemic stroke. Get phone calls right now. Okay, call back. Embolic strokes. The emboli traveling through the artery can occlude the artery, and it can cause ischemia distal to that occlusion. So let me just go ahead and review vascular dementia just briefly, so you can sort of know the difference. Let me see. Because the difference between the vascular dementia is the vessel compartment being occluded, but a multi-infarct dementia, that's when those very small cholesterol plaques, very small granules, sort of like very small pieces of sand, things like that, maybe calcium deposit or something like that. That's when that constant back and forth swishing of the inside of the vessels, and that's when you get rupture of the plaque, and you get some of those particles to become dislodged, and of course they go downstream, right? But these particles are so small that they don't occlude the vessels, they occlude the microvessels, the smallest ones, right? So one of the differences between the vascular dementias and the multi-infarct dementias, the dementia, is that the blood vessel used to be larger territorial damage. In these small, and whereas in a multi-infarct dementia, these small seeds and everything, they spread throughout the tributaries. Wherever the arteries go, they spread throughout, and they create a different type of presentation. And sometimes it can be global, depending on where the occlusions occur. So here, let's look at first explaining vascular dementia. And let me just look at that real briefly. Okay, vascular dementia is a type of dementia caused by reduced blood flow to the brain, right? In a multi-infarct dementia, these small cholesterol plaques go down to a small artery, right? You see how this is, when vascular is on a different scale, leading to damage in brain tissue, right? It's the second most common form of dementia after Alzheimer's, right? Causes improper blood flow, damage to the blood vessels from strokes, many strokes, TIAs, chronic conditions like high blood pressure, diabetes, the types of vascular damage. Stroke related, a major stroke or multiple small strokes, multi-infarct. I won't go and cover that a little bit separately. They're grouping them all together because this is sort of like a summary for Grok. Small vessels disease, gradual damage of the tiny blood vessels. Hold on 1 second. Sorry about that, folks. Okay, where I'm at. Okay, small vessel disease. And look here, here's another concept, right? Mixed dementia, right? You can have one or more that's running simultaneously. And it's important to know, right? Because you would think that if you had an occlusion in the large vessels versus the micro vessels, then you would probably think the treatment strategies or the symptoms would be different, right? Of course they are. The presentation is significantly difficult, are different. Symptoms, cognitive issues, right? Difficulty planning, organizing, problem seeking. That's that frontal lobe impairment, right? Cognitive, that frontal lobe. Memory, the hippocampus. Less prominent in Alzheimer's, but still present. Again, less prominent. The stroke may not destroy all the supply to the hippocampus, and the innervation and the inflammation that results may not destroy the hippocampus completely. So you may have some problems. Physical signs. Remember, strokes that involve the basal ganglia, right? You disrupt those pathways, then you're going to have difficulty coordinating your movement. Now, remember, inside the temporal lobe, you can get the mood changes. Remember the temporal lobe? Mood changes such as depression, apathy, anger, agitation, and things like that. You can also get mood changes with damage to the frontal lobe, particularly personality changes or personality dysfunction secondary to damage in the frontal lobe. Now, this stepwise decline, remember in Alzheimer's, you have a buildup of the intra-inclusion bodies, the tau particles inside the cell. They can get to that it represents sort of intracellular debris. And that debris can build up within the cells to a degree where they can possibly displace the cell body, the nucleus. When that buildup of debris gets too large, cell pops, right? The cell dies, right? Then you get inflammation, right? Then the process worsens, right? And after that process is resolved the best way it can, what happens? The person almost never, with this mechanism, gets back to their original level of functioning. Why? Because the tissue, the nerve cells were destroyed, right? They were destroyed. And if they were destroyed, then that network really wouldn't function at the same efficiency as it did before. So that's the characteristic thing of this. In Alzheimer's, the buildup of the debris is based upon what's happening inside of the cell. That molecular machinery is creating products and things like that, and some of them don't work, so it puts it to the side, right? And that causes the death of the brain cell. That's a gradual process. The buildup of that debris is likely gradual. And then that debris, the particles, is present through all other parts of the brain, but those parts don't die off, right? There's a vulnerability to the hippocampus that causes it to sort of degrade preferentially to the other areas, particularly when you do sampling for all of these tau particles. They're everywhere. They're all parts of the brain. I wouldn't say all, but there are significant parts of the brain. So just the presence of these bodies alone don't mean that it's going to actually destroy the tissue. It's something peculiar about the hippocampus that gives it that vulnerability, right? But there's stair-step phenomena seen in things like strokes and the multi-infarct dementia, whereas in things like things like Alzheimer's, it's a gradual decline, right? One is gradual decline and the other is stair-step decline, right? So those are the sort of like different presentations to these types of strokes and microvascular disorders versus, let's say, Alzheimer's. So that's the step decline here. Risk factors: high blood pressure, pop the vein, pop the vessel, right? Smoking, buildup of the cholesterol plaques, right? That the blood sugar regulation, obesity, right? Deconditioning, that obesity, deconditioning, things like that. Heart disease or over 65. Okay. Okay, so we have that there. This is the multi-infarct. Causes: vascular dementia stems from blood strokes, Alzheimer's for protein plaques and tangles. Vascular dementia progressing stair steps after stroke. Alzheimer's more gradual. Memory loss is more central in Alzheimer's, right? Because it involves the level, whereas vascular dementia anywhere, right? If the vascular dementia, let me also look at blood supply and things like that. Um, okay, vascular dementia. Okay, let's see. Okay, um, multi multi-infarct dementia. Some of the concepts overlap, so I think we'll see the many of the same thing. Multi-infarct dementia is also known as a vascular dementia. It's a form of dementia caused by multiple strokes or infarcts in the brain. These strokes occur when blood flow to the part of the brain is blocked, leading to damage from the affected areas. Over time, the accumulated effects of these infarcts impair cognitive functioning, such as memory, reasoning, and problem solving, detailed below. Causes: strokes, vascular disease, risk factors. I wanted them to go over see if they can go over. Let me just review this so you can see that it's basically pretty much still the same. Risk factor: stroke. Okay. A series of small strokes or infarcts that damage the brain tissue. Okay. These strokes may be caused by blood clots, occlusions, or narrowing. Vascular issues, conditions like high blood pressure, diabetes, high cholesterol, atherosclerosis increase the risk of strokes. And the risk factors: smoking, heart disease, irregular heart rate, AFib, history of stroke, TIA, likely contributing factors. Symptoms. The symptoms it depends on a variety. Depending on the brain region that's affected and the extent of the damage, right? Let me show you the blood supply to the brain. Let me see this. All right. Now, at the level, here's your carotid artery here. That's your common carotid artery. Where is that? I think the bifurcation is here, right here. The bifurcation, internal, external carotid. You can get a lot of buildup plaques here. We typically do a bilateral Doppler ultrasound to see the degree of blockage and everything. And and sometimes you can see studies where it can be completely blocked, completely blocked. And then they may have to go in there and clean it out. But once it gets to that point, then you can see how these particles can travel downstream and disrupt the blood supply. Oh, the anterior cingulate artery, cerebellar artery here. Okay, the anterior cerebellar here. It's been a while since I've reviewed this. Middle cerebral and posterior cerebral artery. Okay. Okay, the anterior cerebral here. Remember the circle realist? Anterior cerebral artery here, middle cerebral artery there. Okay. Here, the anterior cerebral artery here to supply the middle cerebral artery, and then the posterior cerebral artery. Yeah, great. Anterior, anterior sort of wraps insular. Yeah, so anterior, they sort of wrap the internal, and exterior seems to be more. Middle cerebral artery seems to supply more of this temporal lobe and all this parietal lobe and things like that. Huh. Very interesting. Okay. Let me ask this question: How does I want to see a CT scan? Can you show me a CT scan of a person with advanced dementia? Okay, what a CT scan of a multi-infarct dementia shows. Advanced multi-infarct dementia is also known as vascular dementia, results from multiple small strokes that can damage in a different area of the brain. The CT scan revealed evidence of damage. Okay, key findings on the CT scan may include, see, multiple infarcts, right? They appear as distinct dark areas of a low attenuation where the brain tissue has died, right? Look, distinct dark areas of low attenuation, meaning density where the tissue has died. This is often found in the subcortical region and white matter. Right? Second, white matter lesions, right? The scan may show widespread areas of damage in the white matter, the tissue that connects different brain regions. This appears as a reduced density in those areas. Cerebral atrophy, significant. Yeah, you'll see this too. You'll see cerebral atrophy. Yeah, and you can see this in the elderly often also. Um, yeah, yeah. The way I sort of can imagine, it's important. I mean, it's critical to help explain this to the patients, to the families. It's critical because they need to be prepared with the how this disease process progresses, how it advances. And it advances in that stair step phenomenon, which is very difficult for loved ones to conceive and to sort of handle. So you have to be very meticulous in helping them understand exactly what's going on, because they can mistake the significant decline in capabilities to the treatment and not the disease process. So you have to help them understand. I'm not sure how long he gonna remain here before there's a next step down. Hold on one second. Okay. All right. Where am I at now? Okay. Okay. So yeah, you have to prepare the families that because they'll bring mom and dad in not feeling well, but then several days later they can't think, or they can't focus, or they can't concentrate, or they get out of the bed, and the first thing the family assumes is, hey, what medications did you give them? When we came here at 9 o'clock, she was doing well, and you gave her the medications at 12, and now it's 2 o'clock and she can't even wake up. And why did you give her that medications? And please don't give her that medications again. Don't give her that medications again. If they don't understand the disease process in the effort to protect their family members, they may take over the treatment. And what do you do there? I mean, that's difficult. They want to protect their loved ones, particularly from you, particularly if they brought them into the hospital and the patient is not doing well. So I think education. So whenever I pick up these disorders, Alzheimer's is different because they're just not forgetful, right? So they tend to be not disruptive and laid back, particularly in early stages. When Parkinson's dementia, they can't really move that well. It's a movement disorder like dementia, right? Huntington's disease, they still intact, but they just got the career form movement and things like that. What else we have? Frontal temporal lobe different. I mean, they get it in all the time. I mean, all the time, right? But this is different. This is the type of dementia where they're sort of doing well, and then all of a sudden they get some confused. They had the turkey dinner, have too much tyramine from the turkey, right? And get a clouded sensorium and everything, and just difficulty and things like that. Then they come to the hospital, and now if something 12 hours later, they're very hard to arouse, right? And that's the disease process. So you have to prepare them and help them understand the chronicity of this and how this stair-step phenomenon, the stair-step phenomenon, and all of these changes are also associated with sundowning syndrome. And so sundowning is when they become confused when the sun starts to set. And that makes the situation even more complicated if they start sundowning or start becoming confused. Now, because the damage is secondary to the small plaques, how do we know where they're going to land? And this is coded on the inside of the entire arterial system, not just one location. And there's no way to predict how these emboli are going to break off. There's no way to predict how large they are. There's no way to predict what tributaries or what branches or main stalks of arterial arteries are going to be affected. And that process continues to go on without us having any ability to stop it. Right? I mean, how are you going to stop microscopic plaques breaking off from the inside of someone's arteries? You can't do that. It's not possible. Right? So let's see here. While CT scan can reveal infarcts and general brain atrophy, it provides less detail than an MRI. An MRI is more sensitive in detecting smaller changes associated with cognitive impairment. The MRI is more sensitive in detecting smaller changes associated with cognitive impairment, especially the brain white matter. For this reason, the MRI is often preferred imaging for the diagnosis and distinguishing between the types of dementias. Let me see this. CT scan of multi-infarct shows the presence CT scan of multi-infarct dementia showing the presence of 3 large infarcts. Okay, in the chronic stage on the left hemisphere and the one subacute. Okay, yeah. All right, so this one's a little bit darker, so subacute. So this is, yeah, so here's the chronic area here. Here's the chronic. This is not a good, that's not a good scan for me. And again, I'm not a radiologist, so I don't want to point something out wrong. But yeah, look at CT scan. All right, let me get this off. I need to check up on that. I need to go back over CT scans before I do a lecture. Let's see. Okay, in the treatment. So yeah, basically you have to look at what you're dealing with there. If there's any type of psychoticism, which it can be, if it interferes with that mesocortical pathway or the other dopaminergic pathways, you can have symptoms consistent with psychoticism. Psychosis. You can have clusters of symptoms consistent with mood disorders, whether or not they're depression or mania or mixed manic episodes. You can also have a range of cognitive problems if it involves the hippocampus, if it involves the prefrontal cortex, specifically the areas of your working memory. The prefrontal cortex is also the area that houses your working memory. And your working memory is all, you have to remember 10 things at the same time in order to complete a task. And so working memory is the past capacity to remember all those 10. Remember, we do the testing on some patients and neuropsych testings, and sometimes we pick up cases where they can only remember like 3 out of 10. And that's the significant impairment in working memory, which is a reflection of impairment in the prefrontal cortex. We're at 25 minutes, and I didn't know I was going to go this long on multi-infarct dementia, but let me see if I have any questions, okay? Say, hey, Patel, how's it going, buddy? Okay, what is the timing of the stepwise decline that you're seeing? Days, weeks, months? Hey, I just say, hey, hold your hands like this, because when it arrives, you're going to have to be prepared to sort of really stick to your understanding of these processes. Okay, let's see. Okay, hey, Ahash, how's it going, buddy? How do small strokes collectively impair memory and cognition? See, it's a showering of very small microscopic emboli, and that shower constantly goes, and it constantly causes the occlusions, which causes the hypoxia, which eventually causes the brain cell death. And then on MRI, you pick it up as dead tissue, which is darker, right? And you sometimes check me on this. Somebody check me on this. Sometime, if I can recall, they may be described as lacunar infarcts. Check that on the CT scan if this course is lacunar infarcts. Okay. And then there's Ikra. Hey, Ikra, how's it going, buddy? Can multi-infarct dementia coexist with other dementias? Yes, yes, yes. Imagine someone with a predilection for Alzheimer's dementia, which involves the hippocampus only initially, at least initially in the initial stages, right? Imagine them having a very bad diet with all the risk factors. Of course, the cholesterol is going to build up. Of course, that process can take place. And so in this case, you can see how a multi-infarct dementia can coexist with Alzheimer's. And you have to look for that on the CT scan. If you start seeing these multi-infarct lesions and things like that these infarcts, multiple places, and the patient has significant memory deficits that seem to coincide with that gradual decline, of course, right? That's good care to be able to separate the dementias. Why? Because the treatment strategies are different for both, and you're going to have to keep track of both of them, right? So you're going to have to treat that Alzheimer's disease separate. You're going to have to give them acetylcholine or whatever you need to sort of get that memory, to improve their memory. In the area of the multi-infarct dementia, where is this going to show up? Where it's going to appear? Anywhere. So you got to assess that. And then the multi-infarct dementia will likely present with the cognitive changes, with the personality changes, with the perceptual changes, and also with the behavioral changes. And so all of those changes in you it could be another process. And so I see it often. Also, patients with Alzheimer's dementia can still have strokes. If they were to have strokes, then there's the second dementia, right? I think that's it for now. I think that's all I need to do here. So we're at 28 minutes. I think I've had enough of this one. This is interesting. I think 30 minutes on this is enough. Please feel free to like, subscribe, and share. And if you're interested in being my patient, if you need inpatient services, you can always call me and I'll admit you and take care of you. Otherwise, read out. You guys take care. Ciao, guys.